Hi, I'm Jacob Ball. I was working with Dr. Fritton in the Department of Orthopedics. And the title of my poster is Cortical Bone Mechanical and Microarchitectural Differences with Bisphosphonate Treatment. So the purpose of my project was to study bisphosphonates, which are commonly prescribed to postmenopausal women who have developed osteoporosis. And osteoporosis means porous bone, so they have low bone mineral mass, and they're prone to fractures, especially in the hip and the spine. So the most common treatment is to give bisphosphonates. In osteoporosis, there's osteoblasts and osteoclasts, and they work antagonistically to regulate the amount of bone that's present. So osteoclasts eat bone away and osteoblasts build bone up. And the bisphosphonates, they inhibit the action of the osteoclasts, so it allows the osteoblasts to build up the bone, and this allows an increase in the bone mass. But this has side effects, and patients who are on long-term bisphosphonate treatments are known to develop something called an atypical fracture. And atypical fractures are fractures that occur in the long part of the femur, and they typically occur, if it's a typical fracture, in the neck of the femur. And they're also from low impact events, so they're termed atypical. So the problem with bisphosphonates is they inhibit the osteoclasts, but these are there to take away bone that's been damaged over time. So there's a buildup of what we think is micro damage, and this could be leading to the development of the atypical fractures. So my project is then exploring the microarchitecture and the mechanical properties in the bone following administration of the treatment. So for my project, we had, with collaborators in Indiana University, we had beagles that were dosed between 1 and 3 years with bisphosphonates. And then we received a section of bone, and we got the entire rib. And then we cut the ribs in half, and then we made, we call them beams. So each rib and cut in half has 2 different cortices, and each cortice can become its own beam. And then from there, once we had made the beams, we did something called dynamic mechanical analysis with DMA testing, and we would be applying a low load of force onto the beams over various frequencies, and then we would measure the mechanical properties to see if there was any changes in their strength. Right, so this is some of the data that we collected. This is animals treated with 3 years of alendronate, which is a bisphosphonate, and these are 1 year alendronate and residronate treatments. And here we're measuring the energy dissipation, and bone needs to dissipate its energy in order to avoid fracture. So what we found was that in these animals treated with 1 and 3 year treatments, that there was a reduction in their ability to dissipate energy. And this is an indicator that patients treated long-term with bisphosphonates might be developing these atypical fractures. So once we found the mechanical data, it was then interesting to us to look at the microarchitecture to see if we could explain what could be causing these changes in the bone strength. So these are sections that I made. So this is a piece of the cortical bone, and we section it and we stain it and put it on a slide. So here, the bone is made of osteons and interstitial tissue. So the osteons really provide the strength to the bone. They kind of work as like rebar in a sense. And then they're the circular pieces, and then interstitial tissue is in between. So we used Photoshop to then outline the different features of the bone. So here, these are osteons that we found. And then here are something called an osteocyte. And there's broken up into interstitial osteocytes and then osteonal osteocytes. And then we analyzed the quantity and the quality. And what we found was that in the animals treated with bisphosphonates for 1 year, there seemed to be a trend that there was an increase in the amount of osteocytes present in the bone. So this was interesting because previous data had shown that with 3 year treatment of bisphosphonates, there was a reduction in the amount of osteocytes. But previous work has shown in vitro that administration of bisphosphonates has increased the longevity of the osteocytes, but at a certain point they're going to taper off and they're going to die naturally. So we might be in that 1 year period where we're increasing the frequency, and if we continue to dose long term, we might see the reductions that have been previously shown in other studies. So in general, what we had found was that high doses of bisphosphonate decreased the ability of cortical bone to dissipate the energy. We didn't observe too many changes in the cortical bone with the 1 year treatment of bisphosphonates, except for the trend in an increase in the amount of osteocytes. Something that could be playing a role in these mechanical changes is bone quality, which is something that we didn't look at, but future studies hope to look at. So bone is also made up of collagen, mineralization, and advanced glycation end products, and all these things affect the strength of the bone. So since we found mechanical changes, these might be playing a role in the early effects that we see, as well as the late effects. So further data will help us to understand how these mechanical changes relate to the microarchitecture and the quality of the bone. Thank you.
Hello, my name is Tashi Brown, and my mentor is Dr. Salgami in the Department of Medicine, the Center of Emerging Pathogens, and my project is toll-like receptors 2 operating as a friend or foe towards CXCL5 gene expression as determined by neutrophilic attraction. So in my experiment, I was determining the attraction of neutrophils in MTB-infected mice. So toll-like receptors 2, which are TLR2, is expressed on the surface of immune cells. CXCL5 is a chemokine for neutrophils, basically stating that they attract neutrophils to the site of an infection. The purpose of my experiment was to determine if TLR2 knockout mice, right here, has a higher expression of the neutrophils versus wild type. And we found that the increase of CXCL5 increases the expression of neutrophils. So right here, you see a majority of the area is brown, which I stain for using immunohistochemistry staining. Majority of this area is brown, which signifies that a lot of neutrophils are in the area versus the wild type mouse that has little neutrophils. So neutrophils act as a friend and a foe towards the host because neutrophils, as you know, ingest bacteria, which helps stop pathogens from emerging in your body. However, a large expression of neutrophils causes tissue damage. So, which also increases on MTB growth. To address this goal, I perform IHC immunohistochemistry staining using Ly6G antibodies, which is a marker for neutrophils, to determine the expression of the neutrophils. I did this by using a primary antibody, which was anti-Ly6G, as a marker for the Ly6G, which is expressed on the surface of neutrophils. We performed indirect staining because it had a better sensitivity of the neutrophils, so we were able to see more brown areas. I counterstained the tissues to have a better visual of where the neutrophils were going to be. So in this diagram right here, I have illustration of how the staining went. So this brown area here is the location of the antigen of interest, which were the Ly6G. This primary antibody conjugated to the Ly6G, so we use anti-Ly6G. The secondary antibody then conjugated to the primary antibody. That's why it's called indirect staining. We then use streptavidin peroxidase to attach to the biotin conjugated secondary antibody, which we then use DAB staining to induce a brown precipitate around the antigen of interest. We concluded that the stained tissues revealed a greater expression of neutrophils, while the wild-type mouse shows an average expression shown here in this diagram. This diagram here shows a higher expression of the TLR2, a higher expression of neutrophils in TLR2 versus the wild-type mice. The scoring here reveals that higher scoring reveals a greater expression of neutrophils versus a lower scoring show a minimum expression of neutrophils here. Future studies will examine the processing of signaling for TLR2. Since we found out that TLR2 inhibits the production of the CXCL5 gene, which the CXCL5 gene is a chemokine for the neutrophil attraction, therefore inhibiting the expression of the gene. And that is it. Thank you and have a good day.
Hey there, I'm Peter Al-Sharif.
I'm Karandeep Randava.
And we're here to present our research, Dr. Park's lab, longevity regulation by histone deacetylase, RBD3, through secreted proteins from the heart. So RBD3 is this histone deacetylase protein that's able to manipulate gene expression that's been shown in other investigations to extend the lifespan of Drosophila, which is our model organism. And it has some homology to a human protein called histone deacetylase number 1. And we've shown in other experiments that downregulating this RPD3 protein actually extends the lifespan. It improves responses to these oxidative stresses like bleach, and then also improves cardiac function and reduces the rate of heart failure, and another paradigm that we don't talk about here. And what we wanted to do in this experiment was to look at some of the downstream effectors of RPD3 and see if there are proteins in between that are mediating these effects on longevity. So what we did was we used this model system called the UAS-Gal4 system. In the UAS-Gal4 system, what we can do is we can insert 2 transgenes, one that drives a tissue-specific Gal4 in any tissue that you could think of, and then another transgene that allows the Gal4 and interaction with the UAS to drive a transgene, any gene that you can think of, in a tissue of choice. So in this experiment, we use RNA interference for the RPD3 protein, RPD3 gene, but you can use reporter systems, you can use many different types of genes. You can upregulate genes, downregulate genes, and what have you. So for our hypothesis, we thought that there might be some heart-specific RPD3 downregulation that influences proteins that are in between this cardiac function improvement, stress resistance improvement, and longevity improvement. So the first thing that we did was we wanted to confirm that RPD3 is actually extending the lifespan. So we did a follow-up experiment where we did a longevity assay, and we found that flies that have RPD3 downregulated actually have an improvement in longevity, about 32% longer lived than the control flies. And then what we did was we reintroduced RPD3 to these flies that have RPD3 downregulation, and it drives the longevity back to about what the control flies have. So this indicates that our system is working as we thought, and that the RNA interference is specific to RPD3, and that is what's causing the longevity improvement.
Now, next we decided to conduct an RNA screening assay in which we looked at all of the RNA within the young flies and old flies and compared which RNA was downregulated and upregulated in both flies. Now remember that this is for RPD3 downregulation, so we wanted to see which downstream genes were upregulated and downregulated. We found that 617 were upregulated while 40 were downregulated, so we decided to look at the biggest increase in upregulation, identifying candidate gene 13155 as the highest increase in expression, and candidate gene 14957 as the highest decrease in expression. That's how we identified 2 cardiokines in which we conducted further studies. Over here, as you can see, typically in a young fly compared to an old fly, in a control fly with no RPD3 downregulation, flies decrease in this 1G in CG13155 expression. Now, if we decreased the RPD3 expression and downregulated it, you can see that the old flies actually mimic the expression of CG13155 within the young flies, showing that this is the process that may contribute to longevity in the old flies. Similarly, CG14957 increased over time from young flies to old flies in control flies with no downregulation. But once flies were downregulated, the amount of CG14957 expression decreased, similar to how the young flies had decreased expression as well. Now, if you look down here, we can see that RPD3 effectors are altered selectively in the cardiac tissue. So if we downregulate RPD3 selectively just in the cardiac tissue, we know that CG13155 and CG14957 are being driven in change specifically in the heart. In head tissue, which we examined in addition to other tissues, there was no change in the other tissues compared to the heart tissue. Heart tissue had the highest change in gene expression, identifying that the heart is where these secreted proteins were come from. Now if we take a look over here, since we identified CG14957 as being increased over the lifespan of a fly, we decided to decrease the expression similar to over here. Decreased expression would actually increase the lifespan of the fly. It extended the lifespan. Compared to the control fly, CG14957 downregulation had increased lifespan. These two trials can be seen right here. So that showed that this downstream effector actually did have an effect on extended lifespan in the fly. Now to conclude, we identified these two genes, CG13155 and CG14957, and we found that overall downregulation of RPD3 resulted in downregulated expression of CG14957 as well. We took that information and decided to just test CG14957 by itself, and we found that that also extended lifespan, showing a similarity between CG14957 and RPD3 downregulation, since they both show the extended aging phenotype. Further studies would probably ascertain the localization of the CG14957 and CG13155. We hypothesized that they were secreted proteins, so further studies would actually see if these were actually secreted from the cell. Additionally, we want to further elucidate the roles and longevity of these two genes, these two candidate genes. Thank you.
Hi, I'm Neil. I'm a first-year medical student working with another medical student, Carly Ray, and our advisor, Dr. Su Ming of neurology. Dr. Su Ming is a pediatric neurologist, and her interest has been in autism and ADHD. So for this study, we were interested in whether or not children or teens with ADHD might have more GI symptoms than other kids. So what we did was we took a survey and we asked 6 different questions, whether or not they had constipation, diarrhea, stool consistency, stool smell, flatulence, or abdominal pain. And each of these was scored between 0 to 3 for a total of 18. It was particularly important that we captured pure ADHD and not ADHD with learning disabilities or other neural problems. And our healthy children were selected from pediatrics, where they were visiting for healthy visits or like vaccine shots. So in our control, we had 72 healthy patients, and then in our ADHD, we had 68. Our mean age was about 10 years old, and our results. For ADHD, we found that in our survey, the mean total GI score was 1.13, and our control was 0.38. So the difference was significant when we looked at the difference between the means between ADHD and control. And this chart would show that. We also ran a chi-square analysis between all the individual items that I previously mentioned, and we found that constipation, flatulence, and abdominal pain were significantly different between the ADHD and the control groups. And you can see that here. So what is interesting about this result is that the ADHD group was higher, so it might suggest that there was a greater prevalence of GI symptoms in our cohort. And also that because of the constipation, flatulence, and abdominal pain was also higher, that they might be feeling mild GI dysfunction. But the problem that we have with this study is that the mean GI score was 1 versus 0 basically, and that isn't stratified enough to suggest that there is a huge important difference. And so, for example, we couldn't suggest that physicians screen all their ADHD population for GI symptoms. So what we want to do to further this study is to capture a greater sample size, get more patients, and then maybe develop a more sensitive scale to try to stratify the results. In future studies, we might also look at the stool samples of ADHD population and run metabolomic testing, or to look at chemical properties of bacteria in the stool sample to try to capture that information as well. And that would be the direction of our future study. Thank you.
My name is Cesar Clark. I attend Rutgers New Brunswick School. My mentor for this research is Dr. Freden Wright, and he's in the Department of Cell Biology and Molecular Science. I will pass it over to my partner to introduce herself.
Hello, I'm Evelyn Ortiz. I attend St. Peter's University in Jersey City, and our mentor was Dr. Friedenrock, and we are both part of the NERA Phase 3 research program.
Okay, so in our research, we look specifically at the 8 gene, which is the inhibitor of protein gene. This gene plays a role in cardiac development and blood production. In order to study the function of this gene, previous study was done where they did a conditional knockout of ID3 and ID1 gene. ID3 was removed globally in the mice cell, while ID1 was only removed in the endocardium of the heart, hematopoietic cells, and the endothelium. In those mice, cardiac defects was observed. In order to study the function of the absence of ID1, specifically in the hematopoietic cells, they also realized that that contributed to the cardiac defects observed, which lead us to the question to whether which specific blood lineage caused the cardiac defects we observe in our research here. And I just want to pass it over to my partner for the method section.
There were a series of technical methods that we conducted, particularly one for genotyping to determine whether lyse MCRE was present in the mice or if it was absent in the mice. We also did a series of histopathological techniques, which allowed us to visualize the fibrosis present within the tissues of the mice. Particularly, we conducted H&D stainings and Mason trichrome stainings, which we can see here. We see the wild type cardiac muscle and the wild type spleen tissue. These are normal, but with the Mason trichrome staining, we see a deep purple or a deep blue present in the absence of the ID1 gene. Here we see the deep purple or the deep blue representation of fibrosis, and also in this picture it's a little more difficult to see, but we see the blue or the deep blue here.
And these are the results that we obtained from the genotyping. Here we just state the genotype of the parent mice. The male was ID1 flux, ID3 minus, and the female was lyse ID1 flux plus, ID3 minus. When they mate together, they form a mice that we are specifically studying, which contains a lyse MCRE with the ID1 flux, ID3 minus. So in this mice, ID1 was specifically removed in the myeloid blood lineage. Here, we just use this result to basically formulate the genotype of the mice that we're interested in. So in order to test whether the genotype was working, and then at the bottom half, we knew those mice contained the lyse MCRE. At the top half, we wanted to figure that out. So if you see a band lit at the top half, that signified that lyse MCRE was present in that mice, as opposed to if there wasn't a band at the top half, that mice didn't have lyse MCRE. In this bottom result, this is basically showing whether or not ID1 was present as flux and or ID1 flux plus. Since there are different lengths of DNA fragments, the bigger one would move slower as opposed to the smaller one. So if you see two bands, we know that that mice had an ID1 flux plus, as opposed to one band, it's ID1 flux. And if ID1 flux and lyse MCRE is present in a mice, then that mice would have ID1 absent specifically in the myeloid region, and that's what we're interested in.
So the absence of ID1 specifically in the myeloid can be a significant reason for the hematopoietic and the cardiac defects observed in these mice, specifically seen here with the fibrosis in the cardiac tissue and the spleen tissue as well. Through these findings, we can possibly obtain an ID deficiency test to test for ID deficiencies prior to bone marrow transplantations. And we would just like to thank Dr. Soda Green and everyone in the lab for allowing us to take part in their experiment, and also the NERA Phase 3 program and Dr. Friedenrock and Dr. Zhao. Thank you.
Hi, my name is Daniel Coban. I'm going to be a second year this coming fall. And I worked under Dr. Sheldon Lin in the Department of Orthopedics, and my project is titled The Effects of Local Vanadium on Osteoporotic Bone Healing in Diabetic Rats. So diabetes is a prevalent disease in the U.S. Most people know that. Osteoporosis is associated with diabetes. So what we looked at is the effects of an insulin mimetic called venatal acetylacetate, or VAC for short, on the bone healing properties of these osteoporotic rats. Just to take you a little bit through the surgical procedure here. So we started with diabetic rats. What's really cool is we're one of, I believe, 3 rat colonies, diabetic rat colonies in North America. So it was an honor and privilege to work with these animals. At 12 weeks, they're considered osteoporotic, and at this time, we would perform a surgery where we bore a hole through the femur and inject 1.5 milligrams per kg of the VAC solution into our experimental rats. After this, we wait 8 weeks and sacrifice the rats and do micro CT analysis on the trabecular bone. What was really great is that we saw a percent trabecular bone volume increase of 4.71% in our rats after 8 weeks. You can sort of visualize this. Right here we have the treated versus contralateral leg in the same rat. So picture one on top is going to be the contralateral untreated left femur versus the right femur that was treated. And you can really look and visualize at some of the trabecular bone growth that was seen. It's really promising. Just for some sort of reference, in my discussion, I talked a little bit about other studies that were done. One of note was Ficini's study, where they actually put another vanadium compound into the drinking water of rats for 12 weeks, and they looked at the trabecular bone growth. They saw a 0.1% increase after about 2 months. You can sort of compare that to our 4.71% increase that we saw. So it definitely seems like a promising solution. I had a great time working with these rats, working with the team. I want to thank Dr. Lin and everyone who helped on this study, and it's been a great experience so far. Thank you.
Hi, my name is Mark Danilla, and I'm a student at Rutgers University in New Brunswick, and I am a rising senior. My major is a cell biology and neuroscience major.
My name is Lindsay Hernandez, and I'm an undergraduate student at Rutgers University. I'm going to be a junior this coming fall, and I'm a genetics major. Our project, our mentor is Dr. Melissa Rogers. Our project is the impact of a new BMP2 regulatory allele on bone calcification. What we studied is a gene called the bone morphogenetic protein 2. It's a morphogen, which is a molecule that acts at a distance, and its concentration influences proliferation, apoptosis, and cell differentiation. Its key role is in healing bone fractures, and what it does is that it puts up something called woven bone, which we will address later. What we did is we took homozygous, heterozygous, and wild-type alleles of the BMP2 alleles, and we compared that. What we did was we deleted an ultra-conserved region in the microRNA, as you can see here. This ultra-conserved region was deleted through something called the Krelox method, which means it's a suppressor of this gene, meaning that if we deleted it, we would expect increased calcification. This is what it looks like when it was deleted. And our hypothesis is that elevated BMP signaling associated with the deletion of the ultra-conserved region would just alter bone morphology. Our first aim was to compare the morphometric density parameters of femurs in healthy adult mice with the wild-type BMP2 allele, or heterozygous or homozygotes with the ultra-conserved sequence deletion. And then our second aim was to compare that to mice with another homozygous knockout. The Klotho gene deals with a Klotho enzyme, which deals with premature aging in bones. And then the way we analyzed these bones was something called the Bruker SkyScan micro-CT machine. The images that we attained from it were these images. These are two different bones dealing with two very outstanding phenotypes that we observed, and our results that we got from the data are going to be presented by Mark.
So as you can see from all the figures of 4A, B, C, and D, we found that the male BMD was not significant and that there was no trend in our BMD for all of the BMP2 genotypes with the healthy mice controlled. Also for the TMD, which measures cortical bone, there is no obvious trend here, especially with all of the BMP genotypes. Also with the BMD, there was a trend, but it was not significant. We saw that this bone, which is a wild type for the BMP2 and a double knockout for the clotho, it was decreasing as we went to the double knockout for the BMP2 allele. Same thing for the female cortical as well. So we saw that there was a decreased trend in the means and for the means here for the healthy mice. So this is the osteoporotic, this one's the healthy mice. Also with our BVTV values, BVTV stands for bone volume to tissue volume density. And this one, we saw that males had larger BVTV ratios than females. So the males were 84.47%, and this one for the females was 82% as well. Also, a significant data point would be our cortical BVTV means for our osteoporotic mice. So mice with wild type genotypes and for the double knockout for the BMP2 allele, they were actually decreasing. So for mice with the wild type, it was 82%, and for mice with the double knockout, it was 74%, N equals 2 and 3 respectively. And so this reduced mineralization and percentage of the trabecular space occupied by that bone support our hypothesis that BMP2 signaling would alter bone morphology and quality. However, although some of our data are not significant, our future direction is to add 1, more sample sizes, and 2, to fix our segmentation approach and to make sure everything's controlled and the amount of images and to our segmentation. All right. I want to thank New Jersey Medical School and our mentor, Dr. Rogers, for having us here and presenting at this symposium.
My name is Pavli Yusuf. I worked with Dr. Chen, who was my mentor. I am a rising second year in the medical school, and I worked on domestic violence intervention in a program that was directed at the Newark public schools. There were 2 elementary schools. The people who worked with me are a medical student, whose name is Aisha Patel, and Simi, who is a PhD student. And we want to thank Dr. Ping Chen for being an amazing mentor. So the objective of this program was directed to inform and educate the children of our community about domestic violence and healthy ways to cope with the stresses that they see. So according to literature that we looked up, domestic violence exposure for children is very common. For example, they are constantly exposed to verbal, physical, and emotional abuse. And these exposures to domestic violence have a lot of dramatic effects on these children as they grow and as they become adults. Events like domestic violence that they're exposed to at early ages can actually make them prone to being perpetuators of violence themselves when they become adults. So what we, so again, as the main objective of our program was to curb these events as much as possible, as well as make the children aware of these things in order to cope with these stresses. So for our methods, we went to the schools. There were 2 of them, 2 elementary schools in Newark, each of them Monday and Tuesday, and each session was about 30 to 45 minutes. In this session, we have usually prepared a presentation slides with colorful schemes and things like that are helpful for the children at this age to grasp. We talked to them for, again, 30 to 45 minutes. We talked about a lot of topics that are very vital to be exposed to early on. For example, like exercise and coping with stress and diet. especially safety planning. For example, we talk to them about what they would do in an emergency, or when they call 911, what are they supposed to tell them. And also we talk to them about diversity and about the importance of recognizing diversity, and we also talk to them about career exploration. So all of these things are, we try to not go too private in order or too intimate with the topics, just so they don't evoke a certain experience in the kids we're trying to teach. So we made sure we touch upon very healthy topics that are known to be very useful for human beings in general. Again, like exercise and healthy diet and all of that. And like we also taught them about calories. We also taught them about how they can be careful with what they eat and their choice of food. So we basically prepared the presentation after every session. So we would sit down and debrief about the topic we discussed, and also prepare for the next session. So pretty much we when we first started the program, of course, since the program objectives weren't really directed at collecting specific data or finding out something, we did like a survey for them to see like what kind of violence they're exposed to, and also like how common it is for them to be exposed to violence. So according to this figure that we did in the very first day, we saw that they are exposed to a significant amount of adult physical violence, so of seeing adults being physically abusive, or psychologically where they or verbal, where they insult each other, or media related, where they see something like a murder scene or something like that. So we found that they were exposed to a huge portion of violence, and we conducted also at the end of the program. So based on what we found in the beginning of the program, we kind of like started the program towards working on these things. So we conducted a survey at the end where we saw that about 40 to 60% of them, more than that even for some of them, were able to grasp most of the information we presented to them. And a quiz was also conducted of like what choices they would do in certain circumstances. For example, like what can you do when you feel angry or hurt? And 100% picked the right answer of exercise, listen to music, or do something else, which is what we taught them. Also, what can you do to stay healthy physically and mentally? And the 92% picked up the right answer, as well as in the last question of like a violence exposure. So basically, in conclusion, we were able to empower our children of our community of ways to deal with stresses like bullying or being exposed to violence in general, and also to protect them from being perpetrators of violence in the future. And our future work will incorporate a lot of the ideas that we've done, and we will modify our curriculum as well as our teaching modalities to hopefully increase this number even more every year. Thank you.
So my name is Matthew Delbert. I'm going into my second year of medical school here at NJMS. I worked with Miss Josephine Shanuda on this project, and Dr. Walter Zaharadny of the pediatric department. So basically what we did was we wanted to see, under the new DSM-5 definition of autism, who was being missed. So DSM-5 came out in 2013, which was an updated version of DSM-4, which is being used for approximately 20 years. And a lot of people were concerned that with this new definition, which seems to have a tighter criteria, that certain populations of children were going to be missed. So we wanted to see, who's being missed, what characteristics they have. So basically the New Jersey Autism Study, which is piloted by the CDC, looked at 4 different counties in New Jersey, and they wanted to find all the children in those counties that were 8 years old in the year 2014 who met the criteria for autism under the older DSM-4 definition. And of those 900 plus children that they identified as qualifying for autism under DSM-4, we found that right down here, 87% of those children were also confirmed under the new DSM-5 definition, but only 13% were not confirmed under DSM-5. And that's a big deal because if you're not getting an autism diagnosis under DSM-5, then it may have implications on the types of services that you're able to receive through insurance, different behavioral therapy services, medical services, etc. Very interesting to us was that under DSM-5, females were more likely to not be confirmed with an autism diagnosis. Autism primarily affects boys anyhow, and this could potentially have implications on the disparity between boys and girls, making it even greater than it already is. We also looked at things like race, ethnicity. Does it matter in terms of your DSM-5 diagnosis? Our data found that there was no disparity based on race. We found that most cases that were being missed under DSM-5 were children that were classified by pediatric experts as only having mild impairments. But very interesting to us was that 32% of children who were classified as having moderate or even severe autism under DSM-4 were being missed under DSM-5. So there's something about this DSM-5 criteria that is making children with even more moderate and severe impairments get missed. And that's sort of troublesome because these are children that obviously need these different services in order to live, somewhat functional lives. So in the future, we'll be very interested to see how the DSM-5 data affects autism prevalence overall. But for now, we have what we have, and we'll see what the future brings. Thank you.
Hello, I'm Joseph Duran, a rising second-year medical student, and my summer research poster is about a surgical technique, an alteration of a surgical technique for the ALIF procedure, which is the anterior lumbar interbody fusion. This is a technique that was created by Dr. Mammis, who was a attending neurosurgeon here. And in this procedure, essentially, you fuse the two vertebrae above and below a disc that might have been degenerated or it's herniating, and you fuse the two vertebrae. You do this over a cage that's inserted between the two vertebrae. Normally, to cause bone to grow over this cage, you need to use some bone from your own body. And they harvest the iliac crest bone as a graft and put it into this cage. That has a lot of complications associated with it, and in 2002 they came up with a growth factor that can accomplish the same goal without this requirement for harvesting bone. So when they first approved it, it was used a lot and they thought it was safe, but they started noticing some complications with it. Since then, a lot more research has been done about it, and they think those complications arise from maybe this BMP coming outside of the cage, because it's put into a sponge that's inserted into the cage. As you can see right here, this is the cage, and inside it the sponge lies with the drug. So Dr. Mammis, in an attempt to try and restrict this drug from getting out of the cage, used another drug called Actifuse, which is right here in this next picture. It is a clay-like material that's also used to cause bone to grow, but it's meant to be packed into bony voids to cause natural bone to replace it. And what he did was he covered the cage that's inserted between the vertebrae with the sponge inside of it, so that none of the sponge and the drug inside it can leak out of the cage. Thus, it's all restricted to the site and will only cause bone growth there. If it gets outside, it could cause inflammation, and it could cause bone to grow in other places that pinches nerves and causes tons of complications. So this all gets replaced by your bone. The drug is restricted to the cage, and their goal is to reduce complications. We did this procedure in about 25 patients, and in these patients we have follow-up for about 2 years. We found that all of them have very good fusion rates, that we take x-rays 3 months, 6 months, and follow up. We judge success by how much pain relief, and all but one had greater than 50% pain relief after this procedure. If you look at this chart right here, it shows just a brief overview of all the results, and so far we've only had one complication, which was a wound seroma. It was taken care of through secondary attention and the office visit, and other than that, we haven't had any major complications associated with this procedure. So the results are promising compared to a lot of the other rates that range from 15 to 40% that are related to BMP itself, and we're in the process of submitting this paper now, and hopefully we can get this published, because we haven't seen many other techniques like this. So we're hopeful of it could be more used to reduce complications associated with BMP use. And that is it.
Hi, my name is Fam Claudius, and I'm a second-year rising medical student.
Hi, I'm Shri. I'm also going to be a rising second year.
So this summer, we worked with Dr. Stanley Weiss and Dr. Daniel Rosenblum, and we went to tobacco retailers near schools. And what we did there was we tried to see what kind of tobacco products they were selling, what kind of advertisements they had, and how these might affect youth smoke initiation. So tobacco is the #1 cause of preventable death in the United States, and 80% of people who smoke begin before their teenage years, before 18. So it's important for us to mitigate the health effects by limiting things that could affect and enhance tobacco youth smoke initiation. So we created our own survey with about 69 questions, and we asked questions about tobacco advertisement colors, prices of tobacco products, presence of products and where they're located, eye levels, buy level, and we analyze all these things to see if they differed in stores near schools versus stores further away from schools.
So in total, we went to 63 stores in the cities of South Orange and Clifton, and we did an observational survey. So everything we did was things that we saw within the store. So we didn't speak to anyone, we didn't question anyone. And of the 63 stores that we went to, 59 were open, and of those, 49 were within a quarter mile of a school. And we have the data presented here. What we did was we divided it into 2 categories based on how close they were to schools. So we did it by 4 blocks and less than 4 blocks. And what we found was that all 59 stores sold cigarettes, and that's kind of striking. And about a third sold e-cigarettes. And here we highlighted the trends that we saw in orange. One thing that we found was that hookah was more likely to be sold in stores near schools, and stores near schools were also more likely to have ads, both exterior ads and interior ads. And another thing that was really striking to us was in regards to pricing of the cigarettes. What we found is that stores near schools are more likely to have cigarette packs below $6, and stores that are further away are more likely to have more expensive cigarette packs, so above $10. However, the price of the cheapest pack was cheaper further from school, and this is in paradox with electronic cigarette pricing, which was cheaper near schools. And this was concerning to us because electronic cigarettes is something that's more advertised to youth, and it's very popular right now. People think it's a safer alternative, even though it contains nicotine, just as cigarette does, and it's usually the gateway into doing combustible cigarette smoking. And so the results that we found with regards to electronic cigarette pricing approach statistical significance with the t-test. And we're hoping, we also looked at other things such as coloring, product placement, and whether ads had things like cartoons, things that kids would look at. And we highlighted the trends that we saw, but the thing that we want to point out most from our poster is the pricing of electronic cigarettes, as it kind of shows a more focused approach by retailers to market electronic cigarettes rather than normal cigarettes for kids. So, and what we're hoping to achieve from this is policy change, and FAM will go into that.
So yeah, the law passed last week states that the new age of sale will be 21. But the law without enforcement is useless, right? So the FDA actually goes to tobacco retailers near schools and they check to see if they're selling to minors. However, it's not that thorough. Only 21 stores that we went to had a minor involved in an inspection. So of those 21, 5 had violations. So a quarter of the inspections that had a minor involved had a violation. So clearly the enforcement of this law is not that great. So going forward, the policy change needs to be centered around the sale of tobacco products, perhaps limiting sale or prohibiting sale near schools, and perhaps in restricting advertisement specifics. Thank you very much.
Hi, my name is Marcus Elias. I work with Dr. Robert Jung in the Department of ENT here in the DOC. Our project focused on preoperative CT scans related to cochlear implants of Dr. Jung's patients. And basically our project hypothesized that we could use preoperative CT images and measurements of the CT images and relate that to the surgical difficulty of the cochlear implant for Dr. Jung's patients. So a little bit about cochlear implants. There's internal hardware and external hardware, and a major portion of a cochlear implant surgery is when Dr. Jung has to insert an electrode through the middle ear into the inner ear and through into the basal turn of the cochlea. So right here, inserting the electrode through the basal turn of the cochlea so that the auditory nerve can be stimulated. And so a major part of this surgery is the insertion of this electrode through the middle ear and into the inner ear. So, and right here we have a picture of the round window niche. So this is the area, this is the visualization that Dr. Jung wants to have so that the electrode can be inserted. And it's a very important anatomical location, and there are other important anatomical features. So inferiorly we have the facial nerve, which controls facial expressions we can make. Superiorly we have the chordae tympani, which is involved in taste. So it's very important that we have a clear shot of this so Dr. Jung can successfully implant the electrode through. So we hypothesized that a certain angle in the bony ear canal would correlate with an easier or more difficult surgery for cochlear implants. So for CT analysis, we would take preoperative CT images and analyze them using image J. So here's an example of a CT image. This is the left ear, this is the front, this is the front of the face. So here would be the slope of the bony ear canal. And we are making the measurement so tangential to the bony ear canal, and then making another line parallel to the sagittal plane. So this is the angle we're measuring. And I might add that this whole idea for the study started when Dr. Jung was just making comments to his residents, oh, this is a difficult case because I think the slope of the canal of this patient is going to make for a difficult insertion. So a few of the features of the preoperative CT image, we have the facial nerve right here inferiorly, and we have the facial recess right here. So another measurement we're interested in is the width of the facial recess. So we hypothesized that a wider width of the facial recess would make for an easier electrode insertion. So after analyzing all the CT images, we would look at postoperative notes. My job would be to look at what Dr. Jung did as a compensatory maneuver, which would indicate a more difficult surgery. So one procedure would be wide skeletization of the facial recess. That's the first thing he would do. Another compensatory maneuver he would complete is drilling through the posterior face of the external auditory canal wall, which is shown in this picture. So do you see how this trough kind of obscures the view of the facial, of the round window niche? He would drill a little trough with perhaps a burr to increase the visibility of the round window niche. So hypothesized results, we're still analyzing, so we only have hypothesized results, but as the width of the round window niche increases, the surgical difficulty or number of compensatory maneuvers would decrease, and as the angle of the posterior bony canal increased, we would have fewer compensatory maneuvers. So we're just looking at Dr. Jung's cases right now to eliminate variability of other surgeons. Perhaps in the future we would look at how this could be applied to other surgeons.
Hello, I'm Joseph Duran, and I'm actually doing a presentation for Matthew Flint, whose poster this is, but he could not make it today. He was also working with Dr. Mammis as his mentor, and this poster is about a case report for an anterior lumbar interbody fusion technique, where in this particular case they had to do an alteration to the surgical technique, and we didn't find anyone else doing this in the literature, so we decided to publish it. In this procedure, the goal is to fuse the vertebrae above and below a disc that has a problem where there's mobility loss, there's sliding, so there's lots of risk for paralysis or other complications like chronic pain. And the goal is to stabilize the two vertebrae by fusing into one solid one. In this procedure, they accomplish that by using a cage that they insert between the two vertebrae, and bone grows across and infuses. In this case, they did the approach from the front, thus anterior, and the benefit of that is you can use a larger cage. Also, the benefit of that is that they can take all the vessels in that area and mobilize them and push them to the side, and you actually get a less invasive procedure because you do not have to cut through dangerous vasculature or go through all the intestines and all the organs in the abdomen. So since they mobilize it, in this particular case, a complication arose that they could not mobilize it all the way because the vessels were too delicate and there was a lot of risk. So the amount of mobilization that they did left a smaller window than the size of the cage. This is the cage here in an ALIF procedure, and they were not able to fit it through the small window. So the options then were to abandon the procedure, and they would have to close up, and they would not have been able to do anything to help the patient, or Dr. Mammis came up with the idea of using a T-lift cage. A T-lift cage is this cage right here, and it's usually from a different approach. Instead of going anterior, you can go from behind, and these cages are much smaller because normally you have a smaller window to access them. This particular cage that was used was inserted through the smaller window because it was small enough to fit, and it has the ability to expand, where once you insert the cage, you can crank it and increase the size of the cage while it's already placed in. And right here you can see after the instrument is used to expand the cage, it has larger surface area carving more of the vertebrae, and that's beneficial because it increases the amount of fusion to increase the likelihood that the two vertebrae will fuse and the procedure will be a success. They did this, and there was solid fusion in this patient, and they were able to successfully do the procedure where most of the time you would have to have abandoned it just because the complications that were unforeseen before the surgery. So again, this is Matthew Flint's project, and I'm presenting it for you, and thank you very much.
Hello, my name is Shandy Meal. I am a part of the NEAR program. I am a rising junior, and I've done research on HIV prevalence in a mentally ill population in an urban academic setting. So if you look here at the background, 0.3% of Americans have HIV, whereas 0.1% to 23% of mentally ill patients have HIV. So I wanted to find the prevalence of HIV in the academic setting that I am in, which is at University Hospital Psychiatric Unit. So we did a survey of 834 patients, and we collected information about them. We collected certain variables like the patient demographics, length of stay, legal status, gender, race, disposition, psychiatric diagnosis, and their medical history of those who have HIV. And from the 834 participants in the questionnaire, we found out that 4.4% of the people have HIV. And because we're in Newark, out of the 834 patients that we actually interviewed, you will notice that there's an increase in African Americans, where there's 68% of African Americans out of the total, and 19% of whites. And other is classified as Hispanic, so there's 8.5% of Hispanics and 1% of Asians were taken as the count of the total race. There was actually another study done where out of 1,000 participants, 4.8% had HIV, and that's very similar to the information that I've received from the research that I was doing with Dr. Kennedy. Thank you.
Hi, my name is Finley Gabriel. I'm a rising second-year student. I've been working in the neurosurgery department with Dr. Liu. The title of my project is called Efficacy of Double Flap Reconstruction of Anterior Skull-Base Defects After Combined Transbasal and Endoscopic Endonasal Approach. So the main premise is that if you have a tumor in your anterior skull base, you need to remove it, and after removal, you are left with a defect, and that defect needs to be reconstructed. And the major technique that is used is called the pericranial flap, which is mainly the gold standard for anterior skull base defects and reconstruction. But you can also use something called the nasal septal flap, which provides similar results. But in the case of this study, we use a combined approach where we use a simultaneous use of the pericranial flap and nasal septal flap for reconstruction of the anterior skull base after a combined approach for tumor removal. So my goal is to present the outcomes of and clinical series of patients who basically utilize the double flap reconstruction technique of the anterior skull base. In terms of the methods, we did a retrospective chart review on 9 patients from the years of 2010 to 2017. We looked at demographic data. We looked at the types of surgeries they had, the method of tumor resection, the method of repair, and complications or tumor recurrence of any kind. And here is the reconstruction technique. Below you see a scalp flap, which is basically made by doing a bicoronal incision and removing the scalp, which exposes the pericranium, and we use that to derive the pericranial flap. Also, you see the nasal septal flap, which is also part of the double flap technique, which is derived from the nasal septum. These 2 flaps will be used for reconstruction of the anterior skull base. In terms of results, we had 9 patients in all who underwent a combined transbasal and endoscopic endonasal approach for resection of malignant anterior skull base tumor with significant intracranial extension, followed by successful reconstruction of the cranial base using the double flap technique. In terms of the results, there were 5 men, 4 women. Every patient except 1 had post-radiation therapy. In terms of the outcomes, which is important, there were no CSF leakages of any kind within an average follow-up year of 1.3 years. There also were no secondary flap necrosis, infection, meningitis, epistaxis, tension pneumocystophysis as well, and that's a good thing. Usually those are major complications of skull-based surgeries. Here is basically a depiction of, MRI depiction of what happens in the patient that has a tumor that's in the intracranial compartment. From A to B, you see there's a tumor, and basically these patients had a combined approach for resection of the tumor, and D to F shows what happens post-operatively. Basically, the anterior skull base defect was reconstructed using the pericranial flap and nasal septal flap, and you can see the tumor is gone, and in this patient there were no tumor reoccurrence of any kind. In terms of discussion, there are 2 major key points. One, you really have to look at the surgical technique when you're talking about a double flap technique. In terms of the pericranial flap portion of it, you really want to harvest a large surface area of the pericranium in order to create the pericranial flap. And also in terms of the nasal septal flap, you want to use a relaxing incision on the nasal septum to increase the maximal reach of the nasal septal flap that we're going to harvest, and the surface area for coverage of the defect that is found in the sinonasal cavity. And also, another key thing is looking at why we're using both flaps. We're using both the pericranial flap and nasal septal flap simultaneously helps mitigate each individual flap's points of weaknesses. Also, because in terms of pericranial flap, the point of weakness is usually around the posteriorly and the level of the plano spinodale, and in terms of the nasal septal flap, this point of weakness is usually anteriorly at the point of the frontal sinus. So by using these 2 flaps simultaneously, you mitigate those issues. And overall, the main conclusion is that using both the pericranial flap and nasal septal flap simultaneously for reconstruction of the anterior skull base, it prevents complications of skull base surgeries, such as CFS leakages. And that's like a major complication that we want to avoid within that patient. So using dual flap support is essential for these types of conditions. Thank you.
My name is Max Ward, and I've been working with Dr. Liu in the Department of Neurological Surgery this summer on transcallosal interphonoceal approach to the third ventricle, the road less traveled. So a little bit of background. The third ventricle is one of the most surgically inaccessible regions in the brain. Tumors can often obstruct the cerebral aqueduct and lead to associated hydrocephalus in the lateral ventricles, and patients present with headache, nausea, vomiting, visual disturbances. So these tumors need to be surgically resected, but access to this region is almost impossible without violating some neurologic structure. So there are two main routes, the transcallosal and transcortical approach. Transcortical approach often has postoperative seizure because you're violating some sort of cortical tissue, but the transcallosal approach allows you a natural route down the center of the brain. However, previously people have been afraid of interhemispheric detachment by violation of the corpus callosum. However, it's been shown that smaller lesions actually produce no neurologic deficit. So when you get through the corpus callosum, there's three main approaches. There's a subchoroidal, transforaminal, and interforniceal approach. With the interforniceal approach, you actually get really good central visualization of the third ventricle, which allows you access to tumor bulk, which had been previously hidden by poor angles from the other approaches. Previously, people didn't want to do this approach because it's associated with higher incidence of memory deficit. However, it's been shown that gentle dissection of the bodies of the fornices actually don't produce postoperative memory deficit when done correctly. In our study, we performed a retrospective case review of 16 cases, 14 patients who were operated on for tumors with a transcallosal interforniceal approach. Within this study, there were 8 colloid cysts and then 8 other pathologies. Within the colloid cyst population, there was 100% gross total resection in all patients. However, in the other patients, there was only a 25% incidence of gross total resection. Additionally, the incidence of complications was actually triple in the other when compared to colloid cysts, and their post-operative stay was significantly higher as well. And this pretty much tracks into the literature where the more invasive the tumor, the worse the outcomes. We actually calculated sort of incidence complication rates throughout the entire patient population in the recorded literature. So 418 total patients, and sort of selected complications were about a 36% incidence of short-term memory impairment, a 5% incidence of diabetes insipidus, and about a 1.5% incidence of thalamic stroke. Within our patients, we didn't have any thalamic stroke. However, we did have 1 incidence of diabetes insipidus, 3 cases of short-term memory deficit which resolved, and then some long-term endocrine and electrolyte disturbances. So the point of this study is to provide some technical nuances into the transcallosal interforniceal approach and show that it's a viable option for the resection of third ventricular tumors, and in the hands of a skilled surgeon can be a primary approach to the third ventricle. In the future, more outcome studies are necessary to determine prognostic factors for which patients do best in this approach and which tumors are most amenable to surgical resection. Thank you.
Hi everybody, my name is Amy Song and I am a rising sophomore in the TCNJ and NJMS 7-year medical program. My mentor was Dr. Rogers, and today I'll be presenting on the cis regulation of BMP2 expression in lungs. So here we have a signaling pathway, and so first you have serine and threonine kinase receptors. These receptors are activated when the BMP ligand binds to them. Once they are activated, they can then phosphorylate downstream proteins such as the SMAD protein. And then this phosphorylated complex can go into the nucleus and regulate BMP responsive genes such as lung cancer promoting genes. Previous studies have actually shown that lung cancer cells have higher levels of BMP2 signaling relative to normal cancer cells. Furthermore, previous studies done in our lab have shown that there exists an ultra-conserved sequence that is nearly 300 nucleotides long that actually may have repressive abilities of BMP2 signaling. And so our aim is to understand the role of this ultra-conserved sequence and regulate BMP2 expression, which ideally can help us develop novel cancer therapies. And so for this experiment, we had one allele with the ultra-conserved sequence allele intact, and then the second allele, which had the UCS deletion. And so my hypothesis was that BMP2 signaling will differ in the lungs of homozygous deletion UCS mice relative to wild type and heterozygous mice. So we actually did find that BMP signaling is higher in homozygous delta UCS mice relative to the other 2 genotypes, which does suggest that the ultra-conserved sequence plays a repressive role in regulating BMP2 expression. In contrast, in the inbred strain, as opposed to the outbred strains here, the inbred strain showed the opposite trend and actually showed decreased BMP signaling in the homozygous mice lungs relative to the other 2 genotypes. And so these results suggest that mouse strain, whether it's inbred or outbred, can actually affect BMP signaling. And so BMP signaling is also known to induce BMP-related inhibitors or antagonists, for example, noggin. And so in a future experiment, I would test the hypothesis that the inbred mice had higher levels of induced noggin or antagonists that would actually cause negative feedback in that strain. Thank you.
Hi, my name is Imad Siddiqui, and my project is the image analysis of epithelial migration of the tympanic membrane. I work with Dr. Robert Young up in the Department of Otolaryngology. So our project was to analyze the epithelial cell migration over the tympanic membrane, which is your eardrum. So epithelial cells normally move across the tympanic membrane and out in the ear canal, and those cells will combine with debris in your ear to form ear wax. The problem is that you can form a retraction pocket in your ear. The retraction pockets form when the eardrum, it goes from a flat surface and it starts going into the ear. Now those cells that normally move across the tympanic membrane, now they get a traffic jam because they're trying to get away from the tympanic membrane out the ear canal, but now they start getting clustered up and almost form wrinkles on the eardrum itself. So this retraction pocket and this impaired epithelial cell migration can lead to a lot of different pathological diseases, including a cholesteatoma. So a cholesteatoma is like a tumor, but it basically is a buildup of keratin in epithelial cells that form on the eardrum. Cholesteatomas are very dangerous because they can affect hearing, they can cause infections, and lead to ear drainage. This is an image of a cholesteatoma, and you can see the keratin on the ear and the destruction of the ear. So our project, the retraction pocket is well documented. You can see this epithelial cell migration, and it's been in a lot of literature. However, analysis of this retraction pocket and analysis of the migration hasn't been well quantified. So our objective for this project was to develop a procedure of image analysis that really hones in and describes this epithelial cell migration. So if you see in this image here, we use the convolution filter to really to process the image, the first image, and you can see that the wrinkles that are really highlighted in this image. There's certain lines that form, and this corresponds to that cell migration. That's almost like in a traffic jam that can't move out. On top of this, we used analyze features on the image software tool to highlight each of the ridges. So these ellipses that forms capture these ridges and then form a force vector. And this force vector not only shows the direction of the movement of the cells, but it also actually tells you like the force of migration. And this is the data that we can extract from this program to really describe the migration. We also developed a different tool to analyze and differentiate between a normal eardrum and an eardrum that has the retraction pocket. So if you see here, we used the same retraction pocket that we've been using, and we use a normal eardrum. We put a line through each of them, and this detects sort of the wrinkles that form on the eardrum. On the first line, you see that there's a lot of activity here showing each of the individual ridges on the eardrum, whereas on the normal eardrum, there's a very smooth sort of no ridges, there's no activity. And that's a really quick and easy way to show that there's the wrinkle formation on each of the eardrums. With this project, we were able to develop a really strong and robust procedure that analyzes different eardrums and is able to differentiate between normal and eardrums. However, we look to further get real quantifiable data from these force vectors and from the eardrum, as well as develop a program that allows other otolaryngologists to look at eardrums and be able to differentiate between those that have retraction pockets with the impaired cell migration and those that don't. And with that, we were able to identify those who are at risk for certain disease states like cholesteatomas with the retraction pockets. Thank you very much.
Hello, my name is Subhashini Chandrasekhar. I'm a rising second year, and I worked with Dr. Corey and Dr. Zerth in the ophthalmology department. So what we saw was that there seems to be a big issue with individuals failing to come in for a full clinical examination. This is dangerous because about half the people with vision-threatening diseases do not realize that they have the diseases, and by the time they find out, it's too late because a lot of these are irreversible. So what we tried to do is create a telemedicine program through which you use telecommunications to take data and images, and a physician would remotely be able to analyze the images and give a diagnosis. So this solves the issue of patients not being able to come in for a full clinical examination due to limited access to eye care. So what we did is we had 75 patients who were established at the University Hospital Ophthalmology Department, and we had them go through several stations through the telepresence program. So what would happen is after the patient was done being examined in clinic by an ophthalmologist, we would take them station by station. The first is called the autotonometer, the autorefractor, and these two are the OCT and the retinal camera. The OCT gives us images of the cross-section area of the retina, and it also tells us about retinal thickness and ganglion cell complex loss. And the retinal camera gives us a color image of the fundus. So what the ophthalmologist does is, after receiving all of these images and data analysis, he gives a diagnosis and a treatment recommendation solely based off the telemedicine information. Then what I would do is I would take the conclusions made from telemedicine and compare them to the conclusions made during clinic, because both ophthalmologists were blinded to each other's conclusions. And after combining the information, we saw that there was a strong positive Pearson correlation between the data. So it told us that it is feasible to diagnose glaucoma and do therapy recommendations through telemedicine to solve the issue of patients not having access to eye care. Thank you.
My name is Tim Ganapolsky. I'm a rising second-year medical student, and I've been doing research in the Department of Surgery with Dr. Luis Ulloa. And the particular project that I was working on was an investigation to see how the pro-inflammatory acute response in gram-negative sepsis, which we modeled by injecting mice with lipopolysaccharides, could be different in the morning versus the evening. Now, the reason why we speculated that there would be a difference is because autonomic tone, specifically parasympathetic and sympathetic tone, fluctuate throughout the day as part of the circadian rhythm. Now, the suprachiasmatic nucleus, which is the circadian pacemaker of the brain, innervates the paraventricular nucleus, which regulates parasympathetic and sympathetic activity in the body. We know that this has an effect on the body, and it could have effects on inflammation, pro-inflammatory responses, and anti-inflammatory responses, which has been experimentally demonstrated. One example being through vagus nerve stimulation, reducing the levels of pro-inflammatory cytokines in LPS models of acute endotoxemia. Now, the first experiment that I did was injecting mice with LPS in the morning and the evening and seeing if there would be a difference in their serum levels of TNF, which is one of the pro-inflammatory cytokines produced in endotoxemia, and indeed there was. The PM levels were lower, showing us that there's a less severe inflammatory response in the morning. Next, we wanted to see, okay, is that mediated by the vagus nerve, the parasympathetic nervous system? Well, let's see. Let's try cutting the vagus nerve and seeing what happens. We did that, and we found that the difference between the morning and evening levels of TNF were no longer there. So that's interesting. That shows us that it appears that the vagus nerve is implicated in the circadian difference in the inflammatory response. So the next thing we wanted to do was to see, okay, we know that close to 90% of the TNF and interleukins, pro-inflammatory cytokines produced in sepsis, are in the spleen and under the regulation of the vagus nerve. So we removed the spleen, and we wanted to see what would happen then. Now, as expected, since we know that the spleen produces most of the TNF in acute endotoxemia, we got the expected result in the AM. No spleen, much less TNF. But a strange result was that in PM levels of TNF were actually higher when we removed the spleen, which is very peculiar. So in the current model, it appears that the spleen is actually able to inhibit the production of TNF in other tissues in the evening. And when we remove it, whatever factor it may be producing, whatever action it may be doing to inhibit the production of TNF in other tissues is no longer there. So this is the current model that we have being developed. And some other questions that we want to ask is, okay, we're using LPS models of sepsis, well, LPS models of acute endotoxemia. What if we use a more clinically relevant model of sepsis, cecal ligation and puncture, for example? Will we see an increased mortality in mice that we do this to in the morning versus the evening, for example? Another question we want to ask is, what is this factor that the spleen seems to produce in the evening that suppresses TNF production in other organs? So we're going to keep doing research and try to get the answer. And that's a wrap.
Hi, my name is Alexis Nichapruk. I'm a rising second year here at New Jersey Medical School. I worked with the orthopedics department. My mentors were Dr. Joseph Benevenia and Kathleen Beebe. And I also worked very closely with now one of the first year residents, Joseph Eppolito, who helped me out a lot on this project. But we basically compared two procedures for metastatic lesions to the humerus. We compared osteosynthesis, cemented osteosynthesis, versus endoprosthetic replacement just for the humerus. And basically we wanted to find if there was complication rates, or if the MSTS scores, which is the musculoskeletal tumor system scoring, if there was a difference between those two in those two procedures. And what we found was that the only place where really there was a difference was at the humeral shaft, and also if there was more than 2/3 cortical involvement, which means basically that in other places where, for example, the lesion is not abutting an articulation, or if there's less than 2/3 cortical involvement, and if it's not in the humeral shaft, it's possible to use osteosynthesis, which is less invasive than endoprosthesis, which might actually fare better for the patient in the sense that you don't have to take out their own bone, for example. Obviously, the amount of patients we had for this is not too much. It's about 44 patients, just because this is not a very common thing. And so in the future, we'll be exploring the same thing in the femur, and this study will be expanded to include as many patients as possible. Thank you.
Hi, my name is Aisha. My mentor is Dr. Chen. We've been working with intimate partner violence and associated comorbidities in the OB-GYN clinic here. We screened female pregnant patients for domestic violence. When we found that 12.1% were positive for domestic violence, we used the HITS screening survey. And out of those 12.1%, then we did chart reviews on them. It was about 25 patients, and we looked at associated comorbidities of these patients. And we looked at high-risk pregnancies, smoking, alcohol, PTSD, and STDs and depression. And in those comorbidities, we found that victims of domestic violence have a higher prevalence rate in all these comorbidities than the national average. And since the National Preventative Task Force recommends that every single female of reproductive age gets screened for domestic violence, but only 25% of females actually do, based on my studies, I've shown that it is important to screen females for domestic violence due to the high comorbidities associated with them, and to regularly screen them so they are more likely to be truthful, and then we can combat these comorbidities. Thank you.
Hello, my name is Pamela Jumbo Cueva. I'm a second year medical student here at NJMS, and my mentors are Dr. Syed Sifri and also Dr. Peter Johnston. So my summer project was to work on measuring the amount and the value of salvage items from a medical supply recovery initiative. This initiative is known as Recovery here at NJMS, and it's volunteer-run and supported by the Center for Global Surgery. What we do is we provide a system for the hospital and for our volunteers to collect supplies that would be otherwise discarded from the operating room and other locations at the university hospital. And the recipients of our donations are hospitals in low and middle income countries who demonstrate a need for our supplies, and also surgical organizations that provide surgical missions abroad. Okay, so why did we start this project? A common issue that has been recognized in literature is that tons of medical supplies are discarded every year, and from these medical supplies, at least $15 million of these supplies can be reused or repurposed. So that's what we see in U.S. academic institutions, and although we have this overabundance of supplies are being discarded, we see that hospitals in other countries cannot provide basic medical care because they don't have the supplies to do so. So although many institutions have recognized this problem and they started implementing programs such as ours, there is not enough literature about studies about the logistics of this program. So that's what we're trying to do. We're trying to publish our findings. What I did for this summer, I analyzed the inventory data for 4 months, and I tried to find how much of the supplies that we collected were usable and we could store for donations. I also tried to look at all the different locations that we collected supplies and see what were the most popular items based on amount collected and also on value. And from what we see, as we can see here, from the blue line, which is the total weight of amount collected, the red line is what is actually usable. And we see that there is very little trash generated. So we see that most of the stuff that we collect, we can reuse it. In addition to that, we also found out that our main operating room is the main contributor of supplies, both in terms of amount and value. So that's also something to look at. And we also are analyzing other locations, and we see that we can collect different supplies at different locations. And that's something important because when it comes to our inventory and scheduling shipments, it's important to know how much we have and how much we can send abroad. In addition to that, we have other findings. We found out that in 4 months, we were able to collect over 7,000 supplies, and we also found out that by their estimate value was over 23,000. If we extrapolate that amount, we can also predict that through our program, we can rescue $70,000 worth of supplies. If we use our institution as a model and other U.S. academic centers can recover materials from their hospitals, we can expect to have a $19 million of recovered supplies. So this is like something that could be very beneficial for surgical organizations that need these supplies to provide services, and also for other countries in need abroad. Well, thank you so much.
Hi, my name is Emily Moore. I did a project called Delirium and Spatial Neglect Among Stroke Survivors during Inpatient Rehabilitation with Dr. Olga Bukrina and Dr. A.M. Barrett at Kessler Foundation. And we have here an introduction. Delirium is an acute state of disturbed attention and cognition. Spatial neglect is the failure to orient, respond, or report contralesional stimuli after a brain injury, given that this failure is not explained by another underlying deficit. We found several similarities between delirium and spatial neglect in past work, namely that they're underdiagnosed, they increase mortality, and they complicate stroke recovery. So we found that this may be due to right brain dominant cortical and subcortical networks that are affected during right brain stroke. So we had 3 objectives: to determine if delirium and spatial neglect are more common after right stroke, to determine if they co-occur, and to determine if medication use predicts the presence of delirium. So we did this doing an electronic medical record search for key terms. We did a retrospective chart review of 477 charts using the following criteria. We found that delirium is significantly associated with right stroke as compared to left, and the same for spatial neglect. We did not find a significant association between delirium and spatial neglect, and we found that more than 95% of the patients had polypharmacy, so we didn't investigate this further, and we didn't find that antibiotic or antipsychotic use could predict delirium status. In conclusion, we found, consistent with past work, that delirium may develop in as many as half of right stroke survivors. Delirium and spatial neglect are more common after right stroke. And we could explain that there was no significant association between neglect and delirium by the low number of charts that even mention spatial neglect. And we think that spatial neglect should be more frequently mentioned in admission charts to see this significant association. And we found that delirium may be more affected by the number of medications a patient is taking rather than the type. So for future studies, we're looking at prospective studies and also looking at more demographic factors that could explain our findings. Thank you.
Hello, my name is Reed Munson. I'm a rising second-year medical student here at New Jersey Medical School. I work this summer with Dr. Stanley H. Weiss and Dr. Rosenblum over in the Department of Medicine. So this summer, I worked on a study. I was part of a larger study that looked at drug users and their habits. So we were interested in what dose of methadone these patients were taking at the treatment centers. So for the past year, the study's been ongoing. We visit methadone centers in Elizabeth, Jersey City, and Newark, and we perform a 30-minute interview. Ask them questions about their drug use, smoking history, alcohol use, and other drug histories. So we were curious as to whether a patient's methadone dose, as part of this daily methadone maintenance treatment, played a role in whether or not they relapsed to illicit drugs. Because one of the main goals of methadone treatment is to prevent a patient from returning to using heroin. So we wanted to see if a methadone dose had a positive correlation with a patient's ability to abstain. So in treatment, patients are classified into phases, as you see here, phases 1, 2, 3, 4, 5, 6, 6A, and 6B. And the longer a patient is able to abstain from illicit drugs, 18, 24, and 36 months, they're classified into these phases. So we proposed that these people who abstain the longest have the higher doses, which allows them to prevent using opioids. Because as you may know, methadone acts at the same receptors as heroin, and with the 24-hour half-life, it prevents a patient from having any urge to use, any urge to return using heroin, and it will prevent them from getting any euphoria from using. So of the 221 patients we interviewed, 214 were taking methadone, and we saw here in figure 1, as I show, patients in phase 6, 6A, and 6B had higher doses than those in 1 through 5. The patients in phase 6 had a higher dose than 1 through 5, but it did not reach significance, whereas 6A and 6B, as you see down here in table 2, their p-values did reach statistical significance. So these patients in the later phases had higher doses of methadone. One of the things we're interested in is how a patient's methadone dose changed with time. We theorized that over time a patient's dose would increase, whether that be because that higher dose worked for them or because the doctor kept bumping them up as they kept relapsing. So as I show here in figure 2, there is a positive correlation between a patient's methadone dose and their time in treatment. The R value is unfortunately only 0.17, but it was significant in that a patient's dose did increase with time. So the main focus of the study came after a discussion I had with a patient who told me he's still taking 70 milligrams a day because it allows him to still use Xanax, it still allows him to use heroin. So we want to take a snapshot and see who still used. And we found that patients that used during treatment within the last 2 months, there was a question on part of our survey asked when the last time they used, 25 people did admit to using the last 2 months, and their dose was about 75 milligrams, which was lower than the people that abstained. The abstainers for the past 2 months had a dose of about 85. So the p-value for this graph was 0.037, and these patients that did relapse had in fact lower doses, which meant the methadone wasn't working as effectively. So in all, this study provides data that shows that methadone treatment is certainly long-term. Patients here in 6, 6A, and 6B have been on higher doses for long periods, and they have careers, jobs, and families. They're able to live a stable life. So treatment is long-term, it works long-term, and patients are able to stay away from drugs long-term if they have high doses of methadone. So methadone treatment isn't short-term by any means. Patients need continuous medication, continuous monitoring, continuous methadone, but methadone is only a small part in this, as counseling, a patient's environment, and other risk factors play a role in their success. So future studies could analyze these influences. Thank you.
Hi, I'm Leah George. I'm a rising second year at the medical school. My mentors were Dr. Stan Weiss and Dr. Rosenbaum. So we, as a part of a study on drug users, we completed interviews and we were asked to come up with questions ourselves on what we would like to analyze. So we looked at, after looking at some literature and discussing it with our preceptor, we decided to look at the relation between alcohol consumption and opioid use. So a few basic science literature did discuss how in rats and mice there's chronic exposure to ethanol, which decreased the potency of the opioid agonists. And we wanted to see if this drug use pattern in mice and rats also appeared in our population of drug users. So we did a literature search of like over 1,100 articles, and we couldn't find that any other study really looked at this. So we did find one human study that looked at the frequency of alcohol consumption and how it influenced opioid consumption and pain management after post-op abdominal surgery. And they also found that there was an increased use of opioids to control pain in those that did use frequent alcohol consumption or did have frequent alcohol consumption. So we hypothesized that heavy chronic alcohol drinkers within our population of drug users would have an increased tolerance for opioids. So they might need a higher dose or they might use it more frequently in order to feel that same sensation of euphoria. So this is a survey-based study. We had participants that are drug users that were enrolled in one of 3 facilities that we visited. And our results, we first looked at distribution of levels of alcohol consumption within our population. And so we categorized that based on table 1, which is level of drinking based on the number of drinks per week. So it is gender dependent and based on some literature that we found. And you can see most gender dependent is in moderate and heavy. So in our population, we're going to look at table 2. There was a high proportion of abstain and heavy drinkers in our population. And when comparing females and males, there was equal amounts or about equal amounts in each category with some variation with light and moderate. So next we looked at opioids in relation to alcohol consumption. First we looked at heroin and the frequency of heroin use by drinking level. And we did see that there was an increase in the means for the drinkers. And then we also saw that there was, in a specific trend between light and heavy, that there was statistical significance. Then we looked at non-heroin opioid use and compared that to drinking level. We split up heroin versus non-heroin because we did find in basic science literature that that alcohol might not produce cross-tolerance to multiple opioids, so we wanted to study them separately. So we looked at non-heroin opioid use and the frequency of that with each drinking level, and we again did find that in drinkers there was a higher increase in means as you increased alcohol consumption. As well, you could see in the moderate versus heavy, there's noticeably higher medians compared to the abstain and light. Next, we also looked at methadone dose, so by drinking level, and that was because methadone is also an opioid. And here we could see no obvious trends in either the means nor the median. And this kind of shows how there could be more of a biological effect compared to a more psychological effect that could be influencing the amount of opioid use due to alcohol. Like with the mu opioid receptor, rather than, okay, I'm going to drink a lot of alcohol, then maybe I'm going to also use more drugs. So we do think it might be a little bit more biological based on that. And we would like to continue our study by looking at tobacco and marijuana and comparing that with alcohol use. And we do expect to see no obvious trend because those two do not work on the mu opioid receptor. So overall, our data did support the finding that many drug users that use both like heroin and non-heroin users, there are trends to more frequent opioid use with heavier alcohol consumption. And we are still continuing this to study this positive association between alcohol use and opioid use to further understand the many factors that are involved in understanding the association. Thank you.
Hi, I'm Carly Ray. I'm a rising second-year medical student at NJMS, and I worked under Dr. Su Ming in neurology. And our research was looking into the identification of dystonia in children with autism. So children with autism exhibit a lot of repetitive behaviors and movements, and most of these motor mannerisms are just placed into a broad category called stereotypies. So what we were interested in determining is whether any of these movements are actually dystonic movements or postures. So we used video analysis. We analyzed 20 videotapes of 20 children with autism. And we found postures and movements that we suspect were dystonic in 8 of the 20 children. As you can see in our examples, body sites that we located the dystonia included the hands, the neck, and the eyes. So we saw some spoon deformity of the hands. We saw ocular deviation and cervical deviation. So overall, we believe that we did identify dystonia in some of the children with autism. One potential limitation, a co-founding factor, was medications. 3 of the 8 patients were taking antipsychotics, which have dystonia as a potential side effect. So we would need to look into that further. And in terms of future direction and implications, we would like to develop a standardized video protocol, like a more rigid protocol for the videotape process. And we also believe our results might indicate some sort of link with the basal ganglia and autism. So we would like to look into basal ganglial dysfunction in autism because basal ganglia dysfunction and dystonia is well recognized. Thank you.
Hi, my name is Jasmine, and I am a rising junior at Rutgers Newark. I worked under Dr. Ruth in the Department of Pharmacology, Physiology, and Neuroscience. And her lab does a lot of work with orexin, which is a neuropeptide that's found in the hypothalamus, and it's found to have been related to a lot of functions related to blood pressure, food intake simulation, locomotor activity, which all relate to glucose sensing. So this is a lab that is trying to prevent unawareness about hypoglycemia in relation to type 1 diabetes. So basically my job as a summer intern in this lab was to genotype and to find out which mice were orexin-Cree mice. So the procedure to genotype basically starts with DNA extraction, where we get a sample of a mouse tail and the DNA is lysed and then it's washed with buffer and then it's eluted. And the whole point of this step is to purify the DNA in order for it to be amplified in the next step, which is the polymerase chain reaction, or PCR. So in PCR, we use specific Cree primers that bind to the sequences that we want to be amplified. And then after amplification of the segments that we want, we run them under gel electrophoresis, which basically separates the DNA samples by size and charge. So these are the nanodrop results after the DNA extraction. And the point of this is to kind of tell us how concentrated the DNA really is, if we have a good concentration of it, and if there are any chemical impurities or contaminants. So here, since our ratios were good and they were within normal range, we know that we could proceed to the next step, which is PCR. So here, PCR basically amplifies desired DNA sequences by thermal cycling, which is just a kind of heating and then cooling that happens. So here you see this first initial heating, which denatures the DNA, which is a double helix, and then it becomes 2 strands, so 2 single strands. And then after that, it cools down, and that's the annealing of the primer. So the primer anneals onto the specific sequences that we want to amplify, and then it heats up again so that DNA elongation can happen and new strands are synthesized. So after all of that, we go finally to the gel electrophoresis. So we have the DNA ladder here as a reference, and basically here in this case we had 3 mice that were orexin-Cree mice, and we know that because there are bands in each of those respective lanes. So there's a reagent called ethidium bromide, and basically it binds to the DNA and it's fluorescent under UV light. So if the DNA was amplified in PCR, we know that because of the ethidium bromide and because there's a band there, we know that it's orexin-Cree. So that's basically the work that I did genotyping. Thank you.
Hi, my name is Akash Shah. I'm a rising second year student. My mentor is Dr. Levison. I worked with him this past summer to work on a project that dealt with leukemia inhibitory factor, aka LIF, and we were working with this factor to see how it affects neurologic function post closed-headed injury, and to see what other different cells were that grew around that region. So basically, leukemia inhibitory factor is a cytokine. It's a part of the interleukin-6 family, and it's a pleiotropic factor in the sense that it affects many different parts of the brain. It affects cell proliferation, self-renewal, survival, differentiation, and so there are a lot of different factors that this specific cytokine affects. Not much research has been done in terms of how this factor is upregulated in closed-headed injuries, so we wanted to investigate a little bit further into this. Previously in the lab, we've shown that mice that are haplodeficient in LIF have a reduction in neurologic recovery, and so basically my research dealt with the hypothesis that giving a mouse intranasal LIF would actually help support and bolster neurologic recovery after a closed-headed injury. And so basically the methods, we broke it up into 3 different groups. We had a sham group, which basically had their skin opened up, but there was no actual closed-headed injury produced. Then we had our vehicles, where we gave them a closed-headed injury, and then we had our LIF experimental group, where we gave them a closed-headed injury. However, afterwards, we gave them intranasal LIF. And so basically the closed-headed injury was created with an apparatus. It created the same injury for each group and for each animal. Afterwards, depending on the actual experimental group that we had, We had some that were given acute lift and others were given delayed lift. The acute lift were given lift 4 hours after the injury. The delayed lift mice were given lift 3 days after the injury. And then afterwards, another 3 or 6 days after the lift was administered, we sacrificed the mice and did behavioral experiments. So basically what we saw was that we wanted to show initially that intranasal lift does in fact activate the canonical lift pathway, which is a JAK-STAT pathway. And here we show that in the lift mice, the p-STAT3, which is a downstream molecule in the JAK-STAT pathway, is actually activated after lift administration. We show statistical significance that in this is the vehicle where lift was not administered. This is the experimental where lift was administered, and you can see that there's an upregulation in p-STAT3. So lift does in fact activate the JAK-STAT pathway in the cortex of the brain after given intranasally. Then over here we're trying to show that lift does have a neuroprotective function. Basically this is the sham, B is the vehicle, and C is the lift. And we show that if there's a lot of green, it's showing that there's a lot of cellular damage because fluorogate stands for cellular damage. So basically, in our sham, there's very minimal cellular damage, which it makes sense because they weren't actually given the injury. In the picture B, this was after injury, and you can see that there's a lot of cellular damage. However, after given lift with that same injury, there's a much less cellular damage, a significant amount, and there's a recovery in that cellular function. Then moving on, the figure 4 shows the behavioral experiments for the sham, vehicle, and lift groups. The y-axis shows seconds, and the x-axis shows sham, vehicle, and lift. And this was basically done on a 7mm beam, horizontal beam, and it was basically a time to see how long it took them to traverse that beam from point A to point B. For sham, you can see that it took them about 6 seconds. For the vehicle, it took them about 18 seconds. And then for the lift, you can see that it took them much less time and it went back to around 8 seconds. So there was a significant difference in terms of the lift mice's ability to recover and to kind of mimic the sham mice even after an injury that was the same as the vehicle mice. And you could also see that for the incline beam test. This was an incline beam test at about 30 degrees, and this was also done on a 7mm beam. And you can see that kind of same trend in terms of basically after given lift, their ability to traverse that beam is much quicker, and that kind of correlates to having a recovery in behavioral function. So basically, a lot more research needs to be done on this topic. We're looking into oligodendrocytes, macroglia, microglia, astrocytes, and then also axonal function. And we're going to do some electrophysiology to see the actual how well these axons are stimulating. But more or less, that's going to be one course, and then we're going to also look at cellular proliferation in the SVZ and the SGZ. But more or less, there seems to be some pretty good data showing that lift does in fact help with, it aids neurologic recovery, and it reduces some injury post-injury. Thank you.
Hi, my name is Arsh Shah. I'm a rising junior at the College of New Jersey. So we worked with Dr. Park. This is my colleague.
Hi, my name is Chandni Patel, and I'm a rising junior too at New Jersey Institute of Technology. And this summer we worked with Dr. Park, and our project was effect of RPD3 downregulation on Alzheimer's disease.
Just a little brief overview of Alzheimer's disease itself. It's a neurodegenerative disorder that leads to amnesia, cognitive impairment, and dementia. From previous experiments, we know that that Alzheimer's disease is caused or has an effect through buildup of amyloid beta 42. So basically what we did was that we used RPD3, which is a histone deacylase, to downregulate RPD3 and basically enhance neurodegeneration in fly brains, which was our model organism. And we used that, we did it through the UAS GAL4 system, which...
GALFOR is a transcriptional activator, and its target is upstream activating sequence UAS. So when GALFOR binds to UAS, it leads to activation of expression of amyloid beta 42. Accumulation of amyloid beta 42 is responsible for neurodegeneration in our brain. So that was our control flies, the flies with Alzheimer's disease, and our experiment was to see if the effect of RPD3 downregulation on Alzheimer's disease flies. And we downregulate RPD3 using RNA interference, and we are just trying to interfere with the UAS GALFOR system to see if less expression of amyloid beta 42 will help in less neurodegeneration in flies.
All right, so our hypothesis was just that RPD3 downregulation in the brain extends lifespan while reducing neurodegeneration in the fly brains that's caused by amyloid beta 42 and Alzheimer's disease eventually, if it does go to clinical studies. So the way we did that was through 3 methods: the fly cross, the aging assay, and the climbing assay. The fly cross was basically getting our 3 genotypes. Each of the 3 genotypes were specific to either RPD3 downregulation or having the Alzheimer's disease. So one of the genotypes was just having the Alzheimer's disease, the AB42. The second one was having the AB42 with the downregulation of RPD3 just in the brain. And then the third one was AB42 RPD3 PZ, which is basically a deleterious mutation that is the whole body. So we're comparing the whole body versus the brain versus just having the Alzheimer's disease or the AB42. The aging assay is how we tested for the aging effects of RPD3 downregulation. We started with 5 vials of 20 flies each for each genotype. So essentially we had 100 flies for every single genotype, each of the 3 genotypes, 300 flies in total when we started. And we went through, 40 days, I believe, so far. And every 3 to 4 days, we would transfer the flies to maintain the conditions of the vials, because it does get a little messy in there as the flies reproduce and all that kind of stuff. And then the climbing assay. The climbing assay was how we actually tested the actual neurodegeneration of the flies and how we wanted to show that there is neurodegeneration caused by RPD3 downregulation. The way we did that was that after the aging flies were transferred, we basically tapped the flies about 2 to 3 seconds each, and we videotaped it, and we saw how they would climb up for 30 seconds, intervals of 10 seconds each, and we recorded the data. Here, figure 2 and figure 3, all that, the main reason we have that here is that we want to show the detection of the amyloid beta 42 in the fly brain as the flies age. So this is 3 days old, this is 48 days old. They both have AB42, but you can see that through the arrowheads that as the flies get older, you get more accumulation of the amyloid beta 42 right here. That basically shows that there is neurodegeneration in the flies as they age. Figure 3 basically shows the same thing, but it focuses on the neuronal loss. So if you look at the little arrowheads over here, they're a little smaller, but you can see the holes in the fly brains. That just shows that there is neuronal loss as the flies age, which is basically what we're testing. So our results.
So our results for climbing assay are the black ones are the flies with Alzheimer's disease, and the green one is the flies with RPD3 downregulation in the brain, and the red ones are the flies with RPD3 regulation in the entire body. So we can see some difference between the flies with Alzheimer's and the Alzheimer's flies with RPD3 downregulation. And we can conclude from this graph that flies with RPD3 downregulation have lesser neurodegeneration or reduced neurodegeneration compared to flies with Alzheimer's. This is our comparative study from reference 1, and it shows that Alzheimer's flies have a more neurodegeneration compared to the control flies. The RPD3 downregulated flies have very similar results, so they are pretty close to each other, and that's something up for future research. But the bottom line is that RPD3 downregulation does help to reduce neurodegeneration. The other experiment that we did was aging assay. So this was a comparative study of aging from previous longevity studies, which showed that Alzheimer's flies had a shorter lifespan compared to control flies. This is our experiment. It's been only 30 days so far, so it's an ongoing experiment. But we are expecting the flies with Alzheimer's to have a shorter lifespan compared to the Alzheimer's flies with RPD3 downregulation.
Right. So basically, that was our result. We showed our hypothesis, and that's what we found so far. There still needs to be a lot studies done. We only did this for 30 days starting in the summer. So we didn't see much significance in the aging essay, but we did see a little bit in the climbing essay. So there still needs to be more done throughout the summer, throughout the semester, throughout the years, I guess. But eventually we could do clinical studies. Future research would include anatomical studies, mass specs analysis, any sort of thing that could show the RPD through downregulation and actually prove this research as significant. And yeah, thank you. That was it.